formation of leukotrienes. So the clinical use of steroid anti-inflammatory drugs, as I already said, they are much stronger than non-steroid. So effects will be more, and the clinical use will also be more. So let's see here the list of clinical uses of steroid anti-inflammatory drugs. Adrenal insufficiency. Why? Because it will be like the how to say it, artificial hormones. Yes, artificial hormones instead of our natural hormones, which should be produced by adrenal gland. So if we have any type of insufficiency of adrenal gland, instead of natural, we can use those artificial hormones. In case of arthritis, as this is the, again, inflammation. In collagen diseases, again, inflammation. For bronchial asthma, because these drugs reduce allergic reaction very much, and bronchial asthma, it is directly connected with allergy, the disease which is connected with allergy. Other severe allergic reaction, autoimmune diseases. Why autoimmune? Because this drug has immunodepressing effect. So I will write here that here it will be artificial hormones. Here it will be anti-inflammatory. Anti-inflammatory. Here it will be anti-allergic. Here it will be immunodepressant action. Skin diseases, again for anti-allergic, ulcerative colitis and Crohn's disease for anti-inflammatory, cerebral edema for anti-inflammatory, organ transplantation and skin, this is immunodepressant action, and septic shock for anti-shock action. There is also anti-shock effect. This is because of reducing the thrombocyte aggregating factors and also stimulation of some blood pressure. Okay, we're going next. And the side effects. So as I said already, we have not only just the many therapeutical actions, but also many side effects of these drugs, because they are very, very serious and how to say it, not quite selective. They have effects on different processes in the body. So here we have immunodepressing action, so our body cannot fight infections very well. Also, we have delayed healing of wounds, because this group of drugs can reduce the synthesis of protein. That's why the fibrotic fiber will be less generated. Osteoporosis also can be the reason, the side effect. Growth reduction, retardation in children. Peptic ulcers, again, with the same mechanism, because less prostaglandins for producing the protective mucus. Cushing habitus. Cushing, this is the kind of syndrome in which the patient has a lot of corticoid hormones and his body becomes a little bit changed. He has more fat in the upper part of the body and less in the lower part of the body, and different other physiological problems. Hyperglycemia, because the corticoids, they increase the release of glucose from liver. Muscular weakness, psychiatric disorders, and withdrawal syndrome if you stop taking steroids, because they make you dependent, actually. Drug dependence. Why drug dependence? Because these drugs, glucocorticoids, they replace the natural hormones, replace natural hormones, and because of that, there will be reduced synthesis of glucocorticoids by adrenal gland. Okay, so when you stop taking these drugs, you have less natural glucocorticoids and your body suffers from that withdrawal syndrome, and there should not be any like sudden stop of taking these drugs. It should be gradual. Okay, so be careful. And now we're going to anti-allergic drugs. I will not pay a lot of attention on the different types of allergic reaction. They are usually connected with swellings, like here on this upper lip of this boy, and the rashes. Many types of rashes can be, and not only that. And again, from pathophysiology, we know that allergy is the hypersensitivity disorder of the immune system, and it occurs when the person's immune system reacts to normally harmless substances in the environment like they were harmless. A substance that causes the reaction is called an allergen. These reactions are predictable and rapid. Predictable and rapid. Allergy is one of the 4 forms of hypersensitivity, and it is formally called type 1 immediate hypersensitivity. Allergic reactions are distinctive because the excessive activation of certain white blood cells, lymphocytes, B cells actually, whose role is production of antibodies called immunoglobulin E, IgE. Mast cells are activated and release the mediator of allergy, histamine, that results in the inflammatory response. Okay, so our main mediator is histamine. It is released by mast cell when we have the response of antibodies, immunoglobulin E. So the clinical symptoms associated with histamine release. So what can be? In the mild phase, we have some erythema, urticaria, this is like redness and itching of the skin, and or itching. Mild to moderate, we have some skin reactions, also can be tachycardia, arrhythmias, moderate hypotension, and mild respiratory distress. And in severe, we also call it anaphylactic reactions. We have severe hypertension, ventricular fibrillations, cardiac arrest, can be bronchospasm, and respiratory arrest. So you see, from very simple, mild symptoms to very severe anaphylactic shock symptoms can be the allergic reaction. Okay. Histamine exerts its effects on many tissues and organs. It is not a drug, but is important molecule due to its physiological and pathophysiological actions. Therefore, drugs that inhibit its release or block its receptors, they have a very important therapeutic value. Physiological actions of histamine. Primary, it's the stimulant of gastric acids and pepsin secretion for H2 histamine receptors in the stomach. Acid secretion is enhanced by gastrin and vagal stimulation also, and it also has the role as a neurotransmitter for H3 receptors, both in the CNS and peripheral sites. And pathophysiological actions of histamine, the cellular mediator of immediate hypersensitivity reaction and acute inflammatory response. Anaphylaxis, it causes seasonal allergics, duodenal ulcers. It can be because, why? Because it stimulates the secretion of HCl, more risks of ulcers, systematic mastocytosis, and gastrinoma. Sorry. Two more slides with the pictures of severe allergic reactions, for example, like Quincke's adenoma, angioneurotic adenoma, edema, sorry, edema, Quincke's edema and angioneurotic edema. And these edemas are, of course, produced by different mediators of allergy, including histamine. Here we have two pictures and a little bit text about how it happens. Also, some scaring pictures of severe allergic reactions. Here, these are Stevens-Johnson syndrome. You see very severe skin rashes, very severe. This is an eye. So what can be? This is all allergic reactions. And what are the drugs which are used for the treatment of them? The mildest group is antihistaminics, which are blockers of histamine receptors. Corticosteroids we have already discussed. These are steroid anti-inflammatory drugs. They also have anti-allergic effect. Mast cell stabilizers, which prevent the output of histamine, and anti-leukotriene drugs, because leukotrienes, they are also mediators of some allergic reactions, especially for bronchial asthma patients. So let's see a little bit more about that. For the treatment of the immediate type reaction, we can do what? We can reduce the synthesis and release of histamine with the drugs like cromolyn, ketotifen, and glucocorticoids. Block H1 histamine receptors, so it would be H1 histamine blockers like dimedrol, diprazen, diazolin, loratadine. Drugs which directly bind with histamine, this is histoglobulin, but it is not actually used in everyday practice. We have also reduced the manifestations of hypersensitivity. This is not, pay attention, this is not blocking the allergic reaction. This is just reducing the symptoms of allergic reaction. Yes, for example, adrenomimetics. Why? Because they can constrict the blood vessels, but they don't fight allergy. So don't mix. M2 choline blockers, again, the same. Zafirlukast can reduce the allergic reactions because zafirlukast blocks the leukotriene receptors, and euphyllin, which dilates the bronchi, for example. And also we can reduce the tissue alteration by steroid and non-steroid anti-inflammatory agents, because alteration is the phase of inflammation. And for the treatment of the delayed type reactions, we have some immunosuppressants, cyclosporine, azathioprine, and again reducing the tissue alteration by anti-inflammatory steroids and slowly acting agents like chloroquine, gold-containing agents, and so on. Let's see what do the histaminic receptors in our body do. So H1 receptors. Located in bronchial smooth muscles, they increase the tone of smooth muscles. So by blocking with these drugs, diazolin, dimedrol, we reduce this, yes? In the intestinal smooth muscles, again, increasing the tone. In the heart, reducing the atrioventricular conduction. In the blood vessels, it will dilate the arteries, constrict the veins, and capillaries, increase the permeability. In nerve endings, increase the pain perceptions and itching. That's why we have in allergy, often we have itching. And in CNS, it can have different effects, but predominantly it is activating. H2 receptors we have in the gastric glands, so will be increased secretion of these glands. And in the heart, we have positive iono and chronotropic effects, and in arteries, reducing tone again. So here by H1 and H2, we reduce the tone of arteries. So by these H1 receptors, you see, they have much more effect on actually allergic reactions, yes, because here these are not that allergic. This is about other different problems. And for the anti-allergic drugs, we have some agents which we can compare to each other. So, for example, dimidrol, dipressin, suprestin, tavigil, diazolin, these are drugs of first generation. They have not very long, except diazolin, not very long time of duration, 5 to 8 hours to 12 hours. And these drugs from diazolin, from the second generation, they start acting longer, more than 24 hours, 24-12. And also here we have some sedative actions, and in diazolin we have no sedative action and no M-cholinolytic action. This is very good. Sedative action, why this is bad for us? Because patients, when they have allergic, they take these drugs and they really want to sleep. If you have ever taken such drugs, you know what I'm talking about. You take the drug in the morning and the whole day you are like a sleeping person, or you don't know how to move, you don't want to study, you don't want to work, and so on. So about those histamine-related drugs, once again, the classification, we have mast cell stabilizers, and for these drugs, they do what? They reduce the release of histamine, reduce release of histamine to the blood. Why? Because in the mast cells, because in the mast cells we have that deposition of histamine in the vesicles, and when they are activated, histamine goes out to the blood and gives all such effects. So if we stabilize the mast cell membranes, it will not throw out the histamine. And we have the receptor antagonists, H1 receptor antagonist, H2 receptor antagonist, and H3 receptor agonist and antagonist. I don't know them, but they are okay potential drugs and being developed now, so we don't use them right now. For H2, as we already said, they have more effects on the stomach and others, so we don't study them today. For us today, the more interesting groups is the first and the second. So, as I already paid attention, we have first and second generation of the antihistamine drugs, and here are some examples of the drugs of the first group: diphenhydramine, chloropyramine, clemastine, and so on. And the first generation, that means it is the older generation of drugs. They are used in anaphylaxis and other histamine release, anti-allergic drugs, and they have a very strong sedative action, sleeping action. They can also prevent the motion sickness because they affect in the CNS. Motion sickness is when you feel sick, or when you, for example, travel in the I don't know, travel by plane or even by bus. So because of overexcitation of some structures of the brain, this is also one of the effects of histamine. The side effects of the H1 receptor blockers of first generation is that they can depress the CNS. Also, they can a little bit disturb the GIT functioning, and they also have M-cholinesterase blocking activity. Because of that, we can have some dryness of mucous membranes, eye disorders like blur vision, impotence, dysuria, tachycardia, headache, psychosis, and so on. But this is rare, but sometimes maybe, and tachyphylaxis. The drug interactions with the first generation agents is that they have additive synergism with antimuscarinics or M-choline blockers, like atropine, and they also potentiate the CNS depressants like opioids, sedatives, general narcotic analgesics, alcohol. We know about them. Second generation drugs, they have like cetirizine, phenoxyphenidine, loratadine, desloratadine, loratadine, estimizole, and so on, and they are used only like anti-allergic drugs. The histamine blockers of second and third generation, they have more effect than first generation and longer effect. And what is the most important? Then histamine H1 antagonists have that sedating action, means make people sleep. And second generation, they are non-sedating, not sedating, so they don't make you sleep. Okay, higher. Okay, so the second generation antihistamines, they have higher H1 selectivity, so they have less effect on the stomach and the other organs. They don't have inhibitory effect on CNS and additional anti-allergic mechanisms. Some of them are acting on leukotrienes and antiplatelet activating factor. The mast cell stabilizers. Okay, why we are talking about the mast cells? Mast cells, they are type of leukocytes which have the vesicles with histamine inside. So with histamine inside. What happens when we have the antigen in our blood? The antigen forms the complex with antibody, and this complex goes to the mast cells and binds with the membrane of the mast cells. After this binding, the calcium channels will be opened. Calcium channels are opening, and calcium comes inside the cell. The high level of calcium in the cytoplasm increases the permeability of the membrane for the histamine, and histamine goes out from the mast cells. Okay, and then we know what happens. Histamine gives all the effects of histamines. So the drugs, cromolyn sodium, nidocromyl sodium, ketotifen, and also some corticosteroids, they have, with the supra, it means C above, we have already discussed them in previous slides. So these drugs, they stop this process by blocking the calcium channels. So inhibiting the process here, they don't give the calcium a chance to go inside. So there will be no increase of calcium in the cell, and there will be no release of histamine. And histamine will stay inside the mast cell. So we don't have a lot of histamine release out of these cells. So what can be uses of these drugs? Actually, they are often used for bronchospasm prevention in bronchial asthma. Cromolyn sodium for bronchospasm prevention. Ketotifen also for bronchitis. Also for hay fever, also for some allergic dermatitis. And histoglobulin is the preparation of the human gamma globulin, increases the production of antihistamine antibodies. Well, this drug, I have never seen it in the practice actually, but it directly binds with, it directly binds the globulin because it's like an antibody with histamine. And the last group, anti-leukotriene drugs. Leukotrienes, they are formed from arachidonic acid. Yes, if you remember, if we open our arachidonic acid, where it was, 1 second. Okay, where is it? Aha, here it is. So here again, we're remembering we have phospholipids which convert into arachidonic acid, and then we have two ways. Bicyclooxygenase convert into prostaglandins and prostacyclins and thromboxane, and by the enzyme lipooxygenase makes leukotrienes. Leukotrienes, they are also mediators of allergy. They can make our bronchi to constrict. So that's why we use them as also anti-allergic drugs. the drugs who are against leukotrienes. Okay, and they are monteleucast and zafirleucast. The mechanism is competitive blocking of leukotriene 1 receptors in the bronchi, and sure, they are used for bronchial asthma treatment. The effect of these drugs is bronchoconstriction. And the last slide for today is the treatment of anaphylactic shock. As we discussed, the allergic reaction can be of 3 different types: the mild, moderate, and the severe. So the severe one is anaphylactic shock. And for the treatment of this, we have firstly adrenomimetics like adrenaline, ephedrine, noradrenaline. No, ephedrine is not, because it is long-acting. Adrenaline is better, or noradrenaline, because they constrict the blood vessels and they fight the hypotension, acute hypotension. Glucocorticoids, prednisolone, hydrocortisone, dexamethasone, because these drugs are against allergic reactions. H1 blockers, again, for block histamine allergic effects. Myotropic agents, eophylline, to dilate the bronchi, to relax them. And analeptics like cordamine, sulfacamphocaine. This is for stimulation of the center of breathing and the vasomotor center, so to constrict the blood vessels more. Okay, this is it for today. I hope that everything was clear. See you in the practical